Hi, we're here at the 2023 AATS Mitral Conclave. I'm Dr. Randy Martin. I'm thrilled to be joined with Dr. Frank Wells from the UK, from Cambridge. Frank, you've been a giant in the field for years, and you've really been not only an excellent surgeon, I can say that honestly, but also an excellent academician about how you approach surgery and really the history of surgery. Where do you think we are today with mitral surgery, and where do you think we're going?
It is a loaded question. And I think it's a very interesting one too, because we've gone from a period where few were doing it, many were doing it badly, to now a really fantastic dissemination of information through meetings like this. And the awareness of the importance of mitral repair has spread out into the cardiological community, which it was slow to do initially. So I think that now is established with people know it is the ideal treatment for patients with severe mitral regurgitation. Now what we have to do is really make sure that the quality is deliverable for all patients, and I think that is the real issue. There is a tendency, it's a quite exciting subject and sexy, and people want to be mitral surgeons, but they don't get the referrals, they haven't had the basic experience, and we're still seeing a lot of patients having mitral valve replacement after attempted and failed mitral repairs. So I think we've got work to do there in disseminating it. And as we've heard already this morning, the way of teaching people, upcoming surgeons, to do this with confidence, because the simple, straightforward P2 prolapse probably doesn't really exist if you want the perfect result. So actually a broad exposure. And I think the trainees and residents spending lots of time with mitral fellowships, so they see case after case after case after case. And as Gilles Dreyfus mentioned this morning, I think David Adams backed up as well, it's not so much can I do and can I do, and it's seeing it and really looking and really seeing, thinking about it, discussing, taking notes. And the way I teach is often I'll open the case, I'll set the case up, and then we'll go step by step through the procedure itself, and then I'll finish off. Because it's quite tiring when you're learning as well. And if you want them to be on best form, you can do that, I think. And then maybe do a different part the next one. And as you know, Randy, there's so much variation, particularly with the Barlows and cases that to expect all trainees to sort of pick it all up very quickly. You can know the moves, you can know the language, but actually what to do and when to do it, that's the experience comes in.
The concept, and obviously you've done it for years and done it at a high level, as has David, as many of the participants at the meeting here.
Sure.
But the concept of a methodologic approach and certain reproducible standards in how you do it, the Carpentier way and the ways, is really very important. It's not just go in and, do a few stitches and get out of there. So that's part of the process. And really, that's what you're saying.
You're absolutely right. It is a process. It's a process of understanding, interpreting, and then really, we've come to use this term a lot, having a toolbox of tricks and using those at the right time. When I set a case up, I have what I call the golden 5 minutes. I always sit down to operate. If you're going to write a letter, you don't stand up, do you? Sit down. And that way I can focus and concentrate and learn the valve. Really look at the valve. The echo tells you a lot, but it doesn't tell you everything. You know better than anybody. So the subvalve apparatus, the leaflet structure, relationships, and so forth. And then you can begin to piece together exactly what you want to do. And you mustn't be surprised in finding secondary and tertiary quaternary lesions, which you've got to be prepared to actually deal with. And if it isn't right when you've done it, to say, that's not right, and do it again. The patient shouldn't leave the operating theatre without a nicely functioning mitral valve.
With minimal to no MR.
Totally right.
So let me ask you, where do you think the field's going? In other words, if you had to look at mitral valve surgery, and we could say throw in some tricuspid in there, where is it going in the next 10 years?
It's gone from a lot of people having a go to more focused centers, and the center here in New York is a great, absolute reference center. I think it is possible to disseminate that by having a lead surgeon helping the others come along. But I still think it needs to be focused. People say 30-year, 40-year, 50-year. That's one a week, one a fortnight. That's not enough. I mean, 2 or 3 a week, you'll get somewhere.
Especially for those whatever complex valves are, the big valves, Barlow's, the commissural areas,
Absolutely.
sort of things, right?
And the other thing, of course, is we cannot ignore the percutaneous interventions, which we've just been hearing, are maturing, and they will continue to do so. And I think one of the things they will be able to offer, perhaps with less invasive percutaneous techniques, is interventions before you get significant ventricular and atrial changes. And that can change the whole dynamic and can give people, because one of the big factors, of course, in mitral regurgitation is ventricular dilatation, atrioventricular annular dilatation.
And atrial enlargement and
atrial
AFib
fibrillation.
and the whole, and you get tricuspid and you don't.
So bringing that intervention back at a way that's cost effective, because that's a big issue as well, you could actually stabilize people for a lifetime with a minimal intervention. I think we may be seeing that further down the track.
It's interesting that the surgical, obviously the interventionalists have taken off in this country and worldwide to have but now mitral and tricuspid.
Yeah.
But the interventionalists have influenced a lot of the young surgeons that they want to be interventional surgeons. I've always worried about, there is some value to volume and experience. And, I don't want a guy who learned how to fly on a Mac computer flying my airplane. I want somebody who looks like us flying the airplane.
I think you strike a really important note there. Cardiologists live in the cath lab, the interventional ones. They're doing it every day, and they're doing it in larger volume surgery. To expect a surgeon in mid-career to go and be able to match that, I think is asking a lot.
Yeah, and I worry about, there has to be some principle of surgery that you've got to learn and experience. Once you do the current tiers, okay, that's very hard to reoperate on.
It is.
It should still be selected for certain patients, and primary repair is still the procedure of choice.
I think so, absolutely. And the other thing we mustn't forget is we have 20, 30, almost 40-year data now on open and now minimal access surgery coming along. We're talking about 5, 7, 8-year real data for percutaneous techniques. So there's a long way to go yet in knowing when we should be moving towards that more. But you are right, and I've been faced with a few of them, and they're not pretty operations, taking those clips off. And
if you were younger, would you be a robotic surgeon now versus an?
I was certainly heading that way. Yeah, absolutely. I think the whole minimal access adventure has been important. It's demonstrated a lot of things. But of course, you're still limited by the size of the instruments, which are held in the hand. The robot changes all of that. They become truly microscopic almost, and therefore you have truly minimal access surgery with tremendous manipulation and manipulability. The only thing they've yet to, I think, master is actually how you use or develop proprioceptive techniques. When some tissues are very, very weak, how do you actually do this safely in all these patients? And that will come. It's just going to take time. But as it becomes more and more used, the cost will come down, development will continue. And I think that's the way it will go.
Let me ask you a final question. You've been to many of these conclaves, and you're an integral part of those. This is a phenomenal event for us to be together, learn, to connect with mentors and people like that. What are your thoughts about it?
Oh, it's a wonderful fellowship. It is above all a fellowship.
Yes, it is.
We're all aiming at this one tiny little thing, which we're trying to sort out. But it's grown, hasn't it? The growth is incredible. I've been lucky to read every one but one. And thinking back to the first one, it was a fantastic idea. But now it's grown into a point where by the end of the 2 days, you're almost exhausted with the mitral valve. You want to rest from it. You've seen practically everything that can be done with it. So I think it's phenomenal. And it's an amazing, immersive experience, for trainees, for us. You always learn something.
I told David years ago that I wish that the cardiologists, especially the non-invasive cardiologists, could be here because it's phenomenal learning. But it's a great way to learn and push the field and encourage. There's a lot of encouraging of young surgeons.
There is, yeah. And the other thing I like too is there isn't this is the only way you do it. There are multiple ways that have to be justified with our peer groups. I loved Carpentier. I loved Club Mitral, which I moderated a few of as well. It had become a little didactic, but this recognizes the multiple options that there are in mitral valve surgery. And it brings us all together, and I think it's wonderful.
Diversity seeking excellence, right?
Yeah,
that's really.
Yeah, absolutely.
You've been a tremendous asset to the field, and It's been wonderful for me to get to know you. And,
Oh, me, you.
thank you very much for joining us.
Great pleasure.
Thank you. And thank you for joining us.